Epidural analgesia is considered to be the best method of labor pain relief. The recent progress in pharmacology has allowed women to have natural childbirth with no pain at any time during the entire period of labor, from the very beginning right up to and including the expulsive period. In this video, we will see one of the most recent advances in labor analgesia, the PIEB.
Labor analgesia is started using an epidural bolus or a spinal dose, the first part of a combined spinal epidural analgesia. Loss of resistance to saline is used by the majority of anaesthetists because it is associated with lower rates of accidental dural and vascular puncture and a less patchy block compared to air. Combined spinal epidural analgesia is an increasingly popular technique for initiating pain relief in labor, with some units using it as their standard technique and others using it according to clinical circumstances. The most commonly used technique in clinical practice is the needle through needle. Usually a characteristic dural click is felt and CSF seen in the hub of the spinal needle. An intrathecal injection is then performed, after which the spinal needle is withdrawn and an epidural catheter is threaded down the epidural needle into the epidural space. As with low-dose epidural analgesia, high-quality pain relief is achieved, allowing mobilization in labor. But the main advantage of CSE compared to low-dose epidural analgesia is the ability of the spinal component to provide rapid onset of pain relief. This makes CSE a particularly attractive option for the provision of analgesia in late labor, or for a parturient with rapid progress in labor, such as a multipara. Whether to initiate analgesia in labor with a low-dose epidural or CSE remains a decision largely based on the preference and familiarity of the anaesthetist with the chosen technique and the clinical circumstances of the parturient. Opinion remains divided over whether CSE should be the technique of choice in all cases, or whether it should be reserved for certain indications. In all cases, pain relief normally lasts no more than 2 to 3 hours, either with drugs administered spinally or through epidural loading. So, the next and important problem is how to maintain an adequate analgesia during the entire duration of labor. Here are some leading experts in this field with their thoughts.
In the beginning, labor analgesia was maintained by intermittent top-up doses given by the anesthesiologist. Injections are usually timed to parturient complaints of pain, and so, unfortunately, the parturient will experience intervals of analgesia after the dose takes effect, alternating with intervals of pain as the analgesia wanes. The first improvement was the introduction of the continuous infusion technique. This resulted in more continuous analgesia for the patient, less need for top-up doses by anesthesiologists, and, of course, better patient satisfaction.
With this regimen, however, local anesthetic doses may be too large, with resulting maternal motor block. This can reduce mobility, pelvic muscle tone, and could impair the ability to push during the second stage of labor. This can potentially result in an increased rate of dystocia and instrumental delivery.
The next improvement in maintenance of labor analgesia was patient-controlled epidural analgesia. This was once again a bolus technique, but the bolus was administered by the patient and not by the anesthesiologist. Compared to continuous epidural infusions, PCEA resulted in lower total dose of local anesthetics used over the course of labor, a decreased need for the physician to administer additional doses of anesthetic, and a lower incidence of motor block. Most frequently, this technique is associated to a continuous background infusion to avoid the pain fluctuation which can be seen with a pure on-demand bolus. However, parturients must be instructed to operate the pump correctly, and in addition there may be some patients who may not wish to control their analgesia because of fatigue, and some may prefer to leave it to the doctor.
The current standard labor epidural analgesic regimens in Europe consist of a local anesthetic in combination with an opioid, given by continuous epidural infusion with or without patient-controlled epidural analgesia boluses. In the continuing evolution of labor analgesia, programmed intermittent epidural bolus, or PIEB, has recently been introduced.
With this technique, the epidural pump is programmed to administer regular boluses of local anesthetic and opioids rather than a continuous infusion.
A systematic review confirmed that PIEB, in comparison to continuous epidural infusion, leads to a reduced local anesthetic consumption, a shorter second stage of labor, and high maternal satisfaction. Finally, there is also a potential that PIEB may improve instrumental delivery rates and the need for anesthesia interventions.
The programmed intermittent epidural bolus technique represents the routine methods for the maintenance of labor analgesia in our institution, thanks to its efficacy, excellent analgesia with few episodes of breakthrough pain, almost no side effects, and very high maternal satisfaction. We have been using PIEB for labor analgesia routinely since 2010, and to date, more than 8,000 parturients have received it for their labor analgesia with no major complications or important technical failures. Our departmental database provided us with a large clinical knowledge of this technique in its everyday use. The women are completely pain-free but can still perceive the sensation of uterine contraction with no numbness of their legs. They are able to walk, to move, to ambulate, and most importantly, they can push actively during the expulsive period. They can also assume any birthing position if they wish, and maintain the sensation of bearing down. All these features have dramatically improved the quality of care and satisfaction of our mothers. Looking at our database, we have also noticed that maternal blood pressure remains constant after each programmed bolus, so allowing the mothers to receive the bolus safely wherever they are. We are particularly excited about this finding because, to our knowledge, it is a very new and important positive feature to be added to the list of the advantages of the PIEB.
One of the important features of PIEB is the reported great maternal satisfaction. Usually, satisfaction is generally high with any of the techniques used, but it has been reported to be higher with PCEA or PIEB than with continuous infusion. Satisfaction is multidimensional. People can be satisfied with some aspects of an experience and dissatisfied with others. Analgesia and satisfaction with analgesia are not equivalent concepts. Continuous infusion is associated with a higher incidence of motor block, top-ups with analgesic fluctuations, and both these aspects may adversely affect maternal satisfaction. PIEB, however, provides continuous and stable analgesia, a sense of control, painless uterine contraction feeling, ability to walk, absence of numbness and motor block, and the ability to push, all important and positive elements in determining maternal satisfaction with labor analgesia. But what is the action mechanism of PIEB? We believe that there may be a more uniform spread of analgesic solutions in the epidural space when they are injected as boluses as opposed to continuous administration. In this simple experiment, you can see that continuous infusion is not really continuous, but it consists of many small intermittent boluses, since the pump pistons generate a predefined pressure on the infusion line at a predefined frequency according to the mode setting. Note that with low injection pressures, as in continuous infusion, the flow is largest from the proximal orifice, and no flow is observed from the distal orifice, rendering a multi-orifice catheter effectively a single orifice variant. When we give a single large bolus, such as 10 ml of the solution, you can see how the diffusion is different and faster. Here you can better see the same experiment with a more sophisticated model. We designed this epidural model by using gelatin having the same density as the epidural space. When the pump delivers the dye at the speed of 10 ml per hour, the spread of the solution is limited to only few epidural segments. And this is the flow during a PIEB bolus. According to in vivo anatomical studies, also in this our experimental model, the distribution of solution in the epidural space is not uniform. Rather than a uniform advancing front, the spread is directed among paths between structures according to pressures by which they are compressed. When the pump is set in PIEB modality, the spread is greater, directed among paths, and more complete when compared to continuous infusion. A fact also confirmed by our in vitro study, which measured the pressures generated by the epidural pump set in the PIEB or continuous infusion mode. In this graph, you can see how the pressure exerted by the pump in the PIEB modality is 4 times greater than that produced by the continuous infusion. The second experimental step was to measure the pressures in vivo. So we measured the epidural pressures in pregnant volunteers. These in vivo results clearly confirmed the greater pressures generated in the epidural space by the PIEB technique when compared to the continuous infusion. This peak pressure returns to the basal values within 10 minutes. This may explain why, clinically, there is greater analgesic success via intermittent boluses than through the continuous infusion method. Given that there is less motor block and fewer instrumental deliveries after PIEB when compared to continuous infusion, we may hypothesize that creating or lessening motor block may be a direct result of the mode of delivery of the epidural solution. Analgesia and motor block are produced by the movement of local anesthetic from the extraneural space into the nerve along a diffusion gradient. Nerve blockade is eventually overcome when the intraneural concentration exceeds the extraneural concentration and the diffusion gradient is reversed. If an ultra-low concentration of local anesthetic is given in intermittent boluses, the blockade of motor fibers is unlikely, as the total amount of local anesthetic inside the nerve is insufficient to block such thick fibers. In the case of continuous infusion, the extraneural concentration of local anesthetic is generally persistently higher than in the intraneural space, and the total concentration inside the nerve is increased and may reach the threshold for motor fiber block even if you are using an ultra-low concentration of local anesthetic. This may explain the frequent occurrence and intensification of motor block during continuous infusion, especially through the time.
Labor pain is dynamic and intensely personal, and with this understanding, clinicians must tailor the analgesic regimen for each of their parturients, so that the birthing experience can be pleasant and memorable. Medical technology has now provided us with more advanced drug delivery systems that, in my opinion, have promising potential to fulfill the maternal requirements of a safe, natural, and painless childbirth.